Thank you. Hi, everyone. For those of you that don't know me, my name's Adrienne Lenhart, and I'm one of the new GI faculty in the Torrance location. And I'm going to be talking today about disordered eating patterns in patients with irritable bowel syndrome. And as Dr. Chang mentioned, I wanted to start off today with a case. And this was a case that I actually saw when I was a GI fellow in Dr. Chang's clinic. And the patient's also been following with Janelle Smith, one of our GI dietitians. So this was a patient that was a 25-year-old male with a history of depression, SIBO, and IBS-D. He said that when we saw him, his symptoms had started about 4 years prior after a GI infection, and he was currently reporting symptoms of daily postprandial abdominal pain and bloating, as well as loose to watery diarrhea. His symptoms were exacerbated by both stress and dietary intake, and when we saw him, he had tried multiple medications for his IBS and was currently on a combination of low-dose Lexapro and amitriptyline. Now, he reported that multiple different foods were triggers for his GI symptoms, including things like dairy, gluten, soy, and eggs, and he was on a very restrictive diet. He said that he ate the same meal for the past 2 to 2.5 years. And that meal consisted of rice noodles, potato, half an onion, fish, frozen pineapple, green beans, multiple seasonings, and white rice. And he did not deviate from this diet. He also admitted to skipping lunch around 4 times a week and had fasted for full days in the past to prevent his GI symptoms. Now, he was very hyper-attentive about any food that went into his body and what symptoms that might produce, and that really caused him to have a fear of introducing new foods into his diet. That was overall affecting his social life, his ability to travel, and his ability to go out to restaurants. He initially had lost about 20 pounds, but really denied any symptoms that were consistent with body dysmorphia. So now I'm going to talk about disordered eating and IBS. Now, for healthy individuals like you and I, we eat for nourishment, to feel full, and for pleasure. But disordered eating patterns can occur when individuals deviate from cultural norms, which in Western society is around 3 meals a day. Now, disordered eating patterns can happen with IBS patients as a way to alleviate or prevent GI symptoms. And examples of this disordered eating patterns can include things like skipping meals or fasting, limiting food intake, or eating a very restrictive diet. But what we as GI physicians need to recognize is when these patterns can shift from a normal response to a GI condition to a pathologic response that can lead to both physical and psychosocial impairment, and potentially something like an eating disorder. Now, as we know, postprandial worsening of GI symptoms is very common in IBS patients. Now, this was a study that looked at 197 patients with IBS who filled out a food frequency questionnaire. And they found that in this study, around 84% of patients reported that their symptoms worsened with food intake. And the most common food group to cause symptoms was incompletely absorbed carbohydrates, things like dairy products, beans, lentils, apples, and flour. And within the same study, the authors also found that IBS patients who had greater symptom severity based on the IBS SSS reported a greater sensitivity to a greater number of food items, as you can see here. This was another dietary survey that looked at 135 patients with IBS here in blue and 111 healthy controls in yellow. And they found that almost 90% of IBS patients reported that their GI symptoms worsened with food intake compared to around 55% of healthy controls. And the most common foods to cause symptoms in this study were things like bread, spicy foods, vegetables, and fatty foods. And among the IBS patients who reported that food worsened their GI symptoms, the most commonly reported symptoms were bloating, followed by abdominal pain, distension, diarrhea, and constipation. Now, in this same study, the authors also found that IBS patients were more likely to alter their diet in order to reduce their GI symptoms compared to controls. And the most commonly eliminated foods by IBS patients included things like milk products, fruit, and vegetables. Now, given the strong association between dietary intake and GI symptoms, multiple elimination diets have been studied in this treatment of IBS, including things like a lactose-free diet, gluten-free diet, and the low Fodmap diet. Now, this was a study that was published at UCLA last year where we looked at different elimination diets in IBS patients and healthy controls. In this study, 346 IBS patients and 170 healthy controls filled out a diet questionnaire which reflected the diet or diets that they consumed most frequently. An exclusion diet in this study was defined as a diet that eliminated food components by choice, and that included things like a vegan, vegetarian, paleo, low FODMAP, and gluten-free diet. And a restricted restrictive diet was a subgroup of an exclusion diet, and that was a diet defined by diets that eliminated foods to alleviate GI symptoms, and that included a low FODMAP, gluten-free, and dairy-free diet. And in this study, they found that IBS patients were more likely to be on a restrictive diet compared to healthy controls. And among IBS patients, as graphed here, those patients on an exclusion diet or restrictive diet reported greater IBS symptoms based on the IBS SSS compared to IBS patients who were not on an exclusion or restrictive diet. Now, I'm not going to go into the low FODMAP diet in detail, as we're all familiar with this diet now and its efficacy in reducing GI symptoms in patients with IBS. But what I do want to remind us all is that it's very important that we have our patients work closely alongside with a GI dietitian, especially during the elimination phase of this diet, as there is a risk for potential nutritional inadequacy and reduced quality of life if patients are doing this diet without guidance, and that can perpetuate disordered eating patterns. Now, as the popularity of the low FODMAP diet and elimination diets grows, it's important for us as physicians to recognize that these restrictive practices can potentially place certain individuals at risk for disordered eating patterns. There was a recent systematic review that was published that showed that around 23% of patients with GI disorders, including IBS, had disordered eating practices. And that included things like lower total food intake, lower caloric intake, irregular meal patterns, restricting food, or skipping meals. Now, not all disordered eating patterns are considered pathologic or harmful. Sometimes food restriction is an appropriate response to triggering GI symptoms. But this can be a maladaptive or pathologic response if patients are inappropriately restricting their foods because of a fear or anxiety that foods will induce GI symptoms. For example, it's an appropriate response if a patient with IBS is prescribed a low FODMAP diet, undergoes a 4 to 6 week elimination period, and then a reintroduction period, and they eliminate those certain foods that cause symptoms. But an inappropriate or maladaptive response may be an IBS patient who selects 10 safe foods from the low FODMAP diet and only eats those foods, refuses to introduce other foods into their diet. And that maladaptive or pathologic response over time can put a patient at risk for something like an eating disorder. Now, we're familiar with eating disorders like anorexia and bulimia, but there's another eating disorder called Avoidant Restrictive Food Intake Disorder, or Arfid, which is less commonly known. Now, most of the literature on Arfid comes from the pediatric and adolescent populations, but this was defined in the DSM-5 a couple of years ago, and the definition has broadened to include adult patients. Arfid is defined as an eating or feeding disturbance characterized by either a lack of interest in food, an avoidance of food based on its sensory characteristics, things like taste, smell, texture, or food-based fear aversions. And it's manifested by a persistent failure to meet appropriate nutritional needs and has to be associated with at least one of the following: significant weight loss, malnutrition, a dependence on enteral feedings or tube feedings, or interference with psychosocial functioning, which could include things like an inability to eat around others or eat at social functionings. One of the differences between Arfid and anorexia is that Arfid patients, there's no body dysmorphia is not present. The motivation behind food avoidance in Arfid patients is not something like weight loss. There's really a lack of literature in the adult GI population regarding Arfid, but this was a study that was published out of the University of Michigan a few years ago. It was the first large prospective study looking at the prevalence of Arfid in adult GI patients, and they used the 9-item Arfid screen in this study. That's a Likert scale which asks questions about picky eating, food avoidance, and fear-based aversions, and a score over 24 was considered a positive screen. Now, in this study, the authors found that around 19.6% of their adult GI patients screened positive for Arfid, which is a pretty high percentage when you think about it, and suggests that Arfid may be an under-recognized condition within our adult GI patients. Now, this was the second study published by the same group at the University of Michigan. This was a retrospective chart review where they looked at 223 patients that were seen by an adult gastroenterologist and a GI health psychologist. And they identified Arfid, the retrospective chart review, based on DSM-5 criteria. And based on retrospective review, they found that around 12.6% of adult GI patients screened or met criteria for Arfid. But what was interesting was that concern for Arfid was not raised in any of these cases. And there was also no difference between Arfid and non-Arfid patients based on gender, age, GI diagnosis, or GI symptom severity. The authors of this study also looked at IBS quality of life scores before and after behavioral health treatment in these GI patients with and without Arfid. And the IBS quality of life subscales are a Likert scale where a higher score indicates a higher quality of life and a lower score indicates a lower quality of life. And you can see here that the pre-treatment Arfid patients are represented in light blue. And you can see that these patients had a greater fear of food avoidance, but actually less body image concerns. And this slide looks at the quality of life scores before and after behavioral health treatment in these patients. And what I want you to gain is that really across the board, after behavioral health treatment, IBS quality of life scores improved across the board, represented by both the light gray and dark gray bars. But what I really want you to gain from this slide is that overall, IBS quality of life scores improved less in the Arfid patients, and that's represented by the light gray bars throughout this graph. So how do we as GI physicians identify disordered eating and eating disorders in our IBS patients? Well, I think the biggest thing is awareness. Awareness that disordered eating patterns and eating disorders can overlap with GI disorders, including IBS, and we really need to be able to identify red flags in these patients. That can include things like progressive food restriction, a refusal to reintegrate foods into the diet, patients having fixed rules about what they will and will not eat, symptoms consistent with body dysmorphia or significant weight loss, or a lack of concern about being on a very restrictive diet, or things like progressive social isolation because of this. Now, in what IBS patients maybe not be such a great idea to recommend a low Fodmap diet or an elimination diet? Well, in general, elimination diets and the low Fodmap diet are appropriately prescribed to IBS patients as part of management, but we should be cautious when prescribing these diets to patients who have a history of an eating disorder, who are engaging in restrictive dietary practices, who are underweight, actively losing weight, or who are already consuming a very limited diet, because these are patients where there is going to be a risk of nutritional insufficiencies or reduced quality of life, and prescribing a elimination diet to this group could again perpetuate restrictive or disordered eating patterns. So we really need to understand what our patients' dietary practices are while we're considering prescribing an elimination diet. So back to our case presentation, as you can see, this patient did have an eating disturbance characterized by food avoidance and fear-based food aversions. He had had weight loss and also an impairment in his psychosocial functioning. So he did meet criteria for Arfid. Is there any additional workup that we would consider doing in these types of patients? Well, as we know, in general, we try to avoid excessive diagnostic testing for patients with irritable bowel syndrome, but I do think there are clinical scenarios where we may consider doing certain blood work just to evaluate for our patients anemic, do they have electrolyte disturbances, consider checking a thyroid level. And there are clinical scenarios where we could consider testing for individual nutrient or vitamin deficiencies. But I would really encourage you to work alongside your GI dietitians if you're considering doing this to make sure that we're ordering the appropriate vitamin or nutrient workup based on what their diet is. So what about management? So currently there are no randomized controlled trials that have looked for specific medications in the management of Arfid. But in general, for our patients with IBS who have overlapping disordered eating patterns or eating disorder, we can medically manage their IBS in similar ways to we would manage other IBS patients. And a lot of times that involves neuromodulator therapy. In our particular patient, for instance, he was continued on a combination of low-dose Lexapro and amitriptyline and did very well from that standpoint. I do want to mention, though, that there have been some case series and case reports from the pediatric literature that has suggested a potential role for things like mirtazapine, olanzapine, or ciproheptadine. Their role for mirtazapine has gained increasing interest because this medication does help with promote appetite, promote weight gain, can help with nausea, vomiting, increasing gastric emptying, and we do use mirtazapine in our adult GI patients with functional dyspepsia. This was a small case series from the pediatric literature where they looked at 14 Arfid patients who had a mean BMI of 16. They were prescribed titrating doses of mirtazapine over an average of 13 weeks and had a significant improvement in their BMI. And it suggests that there may be a potential role for things like mirtazapine in our adult GI patients with IBS who either have overlapping weight loss, overlapping functional dyspepsia, or overlapping Arfid. But really, we need more research in this area. And lastly, what I really want you to gain from the management side or slide is that for our patients with IBS and overlapping disordered eating, we really need to focus on a multidisciplinary and integrated approach to care. We as gastroenterologists can help with the medical management side of things, and we also need to recognize when these disordered eating patterns are occurring so that we can refer our patients to our GI health psychologists who can help with behavioral management. Cognitive behavioral therapy has also been studied in patients with Arfid with some success. And also refer to our GI dietitians who can help with the nutritional aspects of things, food reintroduction, etc. And with that, I want to pass the mic to Janelle Smith, one of our GI dietitians, who's going to talk about disordered eating patterns from a dietitian's perspective.
All right, thank you so much for having me today. I'm going to apologize in advance if I sound out of breath. I have something pressing on my lungs. Just can't get rid of it. So same case presentation. From my perspective as a dietitian, I noticed that he had a lot of psychosocial struggles, including inability to keep a job related to his irritable bowel syndrome, and conflict with his parents about the failure to launch. He did have a pretty premorbid lower body weight, so he's not significantly, he's about 10 pounds lower than his highest weight, but he's never been a very big person. A prior IBS treatment center recommended an allergen-based elimination diet, which Dr. Lennart mentioned. And he's been following it for 3 to 4 years without any reintroduction and not adequate follow-up. He has some limited financial means to following any diet and procuring food, but he's able to prepare all of his own food. He's also been on a low dose of L-glutamine for about a month and a half with no impact so far. I estimated his intake at approximately 1,200 calories today and 40 grams of protein, which is inadequate, and I'll show you what I estimated his needs to be. And he's having flares still with this diet change. He reports a couple times a week. He typically attributes it to eating a new food, but is very unaware of the role of stress in his symptoms. So I do screen all of my GI patients for feeding and eating disorders. Certain screening tools for eating disorders, unfortunately, are not validated in the GI population, and it's assumed that the scores on those screenings are going to be falsely elevated because there is some degree of hypervigilance and additional thought put into food by someone who is controlling a chronic health condition with diet changes. However, I do feel like they're still very informative because there is some very specific disordered eating behaviors you can glean from these, such as fear of weight gain, controlling their diet to change their body shape or size, body image distortion, self-induced vomiting, or laxative use to control body shape or size. Those would not be related to a low Fodmap diet or an elimination diet to control symptoms. Good news is we actually have one new screening tool that was just published that is validated for the fear and Arfid subtype in the GI population. So this has not been thoroughly studied yet, but I'm looking forward to using it. And then we do have a validated tool to use in patients with celiac disease who also have risk of disordered eating. These are some of the traits that I look for in addition to asking specific questions. Feeding disorders such as Arfid, which are not related to body image, are more highly related to those with neurodivergence, developmental disabilities, anxiety disorders, obsessive compulsive disorder, an over-controlled personality type, a medical diagnosis, especially from childhood, and medical trauma. So these are more likely to result in restrictive eating that is not related to body image. Although we do see some of these traits in patients with body image-related eating disorders. So our case study did not screen positive for any body image fears, but did report fear of food due to GI symptoms and some low appetite and difficulty eating enough, which may explain his premorbid, kind of somewhat low body weight. So should an elimination diet be our first recommendation? I would argue no. There are risks to elimination diets, and our jobs as providers are to do no harm first. So if there is time to assess thoroughly and a patient's history and relationship with food, it may absolutely be appropriate to prescribe an elimination diet, but unfortunately a 15-minute consult is often not long enough to do that. Risks include disordered eating, increased stress and anxiety around food. I see that in probably 90% of patients that walk into my office, whether or not we would consider it disordered eating. They definitely have hypervigilance and stress to food. And we have these unknown changes to the gut microbiota long term. I want to just mention that standard care for IBS as a first-line response is effective at reducing symptoms in patients with irritable bowel syndrome. And standard care can be similar to the NICE guidelines that were recently republished, somewhat recently in 2016, which really focus on avoiding irritants such as caffeine, alcohol, spicy food, acknowledge the role of a high-fat meal, which the low Fodmap diet does not, do acknowledge limiting lactose and using fiber in the treatment of irritable bowel syndrome, specifically soluble and low fermentable fibers, rather than anything like wheat bran, which we would not want to do. Not enough evidence for a gluten-free diet or significant impact of probiotics or other elimination diets beyond the low Fodmap diet. I also want to remind you that IBS has many, many modes of treatment, and that if we only focus on diet therapy, that we are likely to exacerbate this relationship with food in our patients. So to remember to use integrative care in terms of addressing all of the symptoms. Plus, there are very few patients for whom diet cures 100% of symptoms, so they're going to need additional interventions at some point. The recommended dietary treatment for Arfid is first and foremost to restore weight and nutritional needs. Basically, a malnourished brain is inflexible. There's reduced neuroplasticity and really heightened fears and hypervigilance. That's an aspect of malnutrition physiologically. So it's very difficult to convince a patient to reintroduce foods when they're already in this high stress state. We can use safe foods first, nutritional supplements, to help to increase their overall energy intake. We can use multivitamins as well, kind of basically whatever a patient is willing to eat first. Then once they're in a better place nutritionally, we want to use exposure and response prevention with new foods to expand their variety. This includes foods that are important to the patient and those that better meet their nutritional needs. So it really depends on the patient's diet and what they've avoided. And we do need to have buy-in from the patient, otherwise we could recreate a medical trauma of coercing or forcing a patient to reintroduce foods that they find disgusting or very harmful. These are some common deficiencies in Arfid depending on the food group eliminated. In our case study, we tried increasing L-glutamine, which had no effect. We used soluble fiber, which was very helpful. We spread out meal intake so that he wasn't just eating 2 huge meals per day. He was eating more so every 3 hours. We tried some minor low Fodmap changes, which were not significantly effective, but most of all, we increased his portion sizes. 8 ounces of salmon a day and 1 cup of starch in each portion. He continued to have this same stir fry, and to this day, up to last week, he continues to eat this stir fry twice a day. Other treatments that we've used for him were Arfid Adult Support Group. He's been seeing a chronic pain specialist once weekly that's really helped him with the cognitive side of managing IBS. Also a neuropsychologist, daily meditation, a Curable app, and reading books and sharing those with his family to have increased support. So we have introduced a few new foods, salad, eggs, spinach, kale, and turkey jerky. There were additional foods that we tried to introduce that he did not tolerate, supposedly. And he's had, most of all, a very significant reduction in flares of pain and diarrhea to only 1 to 2 times a month. And he's much more aware of how stress impacts and triggers these symptoms. Despite that, I would say that he's still struggling with Arfid, and that we need to take the next step in getting him more treatment. He still has high anxiety around introducing foods, and a lot of different rules around introducing these foods that are inconsistent, such as, we'll tolerate a food for several days, and then we'll just eliminate it and forget about it for months on end. Or we'll eliminate a food for 7 days, and on day 7 have a flare, and then attribute it to that food, which is very unlikely that one would eat a food for 7 days in a row and then have a reaction to it. This is not. There we go, okay. So in addition to the treatments that Dr. Leonard was mentioning, I do find that it is often necessary to involve a clinical mental health provider with experience in Arfid and eating disorders that may be able to provide more long-term or more consistent treatment than a GI psychologist. So as GI physicians, my plea as a dietitian is if you have the time to assess, wonderful, that is an amazing relationship that you can build with that patient. But if you have access to a GIRD and you need them to assess, they're much more capable of assessing for which elimination diet and to what degree an elimination diet is indicated. And there are some local, actually, resources for treating Arfid. Here in Beverly Hills, a free adult Arfid support group, as well as clinicians. So thank you so much.